Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and we are going to continue on with our Brain Health Month. Today, we're going to be discussing headaches, understanding tension headaches, symptoms, and treatment. I have Fran West with me. She is with the Center for Neurosciences, and I want to share a little bit about Fran. Fran has come and done some great talks for us. She really dives deep into every topic that we've provided with her. She has been working with, she is a nurse practitioner. Fran received that in 2009. She's a board certified family nurse practitioner, and she has worked with Dr. Teeple since 2013. She is hospital based with Center for Neurosciences. So she works here right at Tucson Medical Center, and she'll be teaching us about tension headaches today. Welcome, Fran.
Thank you. Good afternoon, everybody. My one other thing that I can say is I went through the entire torture of doing a postmaster certification. So I'm also geriatric and acute care certified because I actually started as a nurse practitioner in the ER. So I used to work with small people. Anywho, yes, so I've been with Dr. Teeple, and now we have Dr. Kalilat. So we're a 4-person team, 2 neurologists, 2 nurse practitioners who do only inpatient. Headache, though, is something that is kind of across the board. We see it a lot in clinic, obviously, in neurology clinic and outpatient, but we do a heck of a lot of inpatient as well. Mainly, though, for people who have things like what's called status migrainosus or headaches from something else. Tension headache, which is what I'm going to talk about today. And if people want to know about migraine and everything, I am happy to do a talk, but that is a talk all by itself because that is a broad topic and you cover a lot of, it's an umbrella term and it covers a lot of different subtypes and different types of medication and different types of approaches as far as management. So today I'm going to talk about tension type headache because this is actually probably the most common neurologic disorder out there. Certainly the most prevalent headache disorder. As with many things in neurology, we can tell you what we have. We can't always tell you why you have it. We do think genetics plays a bit of a role. We do think environment plays a role. When they did twin studies, what they found is that people who have frequent episodic tension headache, episodic meaning it comes and goes, or chronic, tended to have more of a genetic component. In those same twins, if they had infrequent episodic, they tended to be more of an environment-based trigger as opposed to genetics. And genetics, of course, is always complicated because even if you have the same genetics in 2 people, their environment may affect to what degree those genes expose. And my other totally informal observation over years and years is if you have any kind of autoimmune disease, rheumatoid arthritis, lupus, Sjogren's, you name it, those people always have headaches. They tend to have migraines, but I swear they must sit next to each other on a chromosome. Okay, so what is tension headache? Muscle contractions of the head and neck is probably the easiest way to think of it. It tends to be a muscle headache. It is associated with stressful events, you have a bad day, etc., because a lot of us spend time sitting over computers. And if you find yourself having the beginning of this headache in your neck and the back of your head, look at your shoulders. Are they up here like this? Because this is often a problem. Even just bad posture can contribute to this. Symptoms can overlap with headache types because there is no cosmic rule that says you only have one thing. So yeah, you could be a migrainer, but you could also have tension headaches. That's not uncommon, unfortunately. So how do we diagnose this? These are the criteria. So you have at least 10 episodes of headache, and it falls in this range. So at least 10 episodes, and that's monthly, looking at a month, not lifetime. So of those 10 episodes, do your headaches last from 30 minutes to a week? So it can last minutes to hours to days. And we count one episode If you have it for 30 minutes one day or an hour or two and it goes away, but it comes back the next day, that's 2 episodes. If you have one headache, and even if it kind of waxes and wanes, but you have a headache and it lasts for days, that's 1 episode. So episode doesn't always tell you duration. You see what I'm saying? So we're looking at things like, do you have more than 10 headache days a month, more than 15 headache days a month? Is it on both sides? So this is actually one of the things that helps us distinguish it from classic migraine. Migraine tends to be one-sided, unilateral. Is it pressure, band-like, tightness? Those are kind of the descriptors people tell us for their headaches. Whereas a classic migraine type headache is throbbing, it's pulsatile. That's not really a tension headache. Mild to moderate intensity. Now, that's important actually, because what that tells you is even if you have this headache chronically and it affects your quality of life, it's not severe, it's not debilitating, it's not going to put you in the hospital, whereas migraines can. There is something called status migrainosus. That's not going to happen with a tension headache. Like I said, it can make you uncomfortable. It can make you not feel great about your life because you're distracted by this thing. But it's not going to be so distracting that you can't eat, you can't sleep, you can't work, and you can't function. And it doesn't cause things like nausea, vomiting, light sensitivity, smell sensitivity, etc. Those are all migraine features. And then of these 2 down here, doesn't fit anything else. So it's like a diagnosis of exclusion. We look at a whole bunch of things. If it doesn't fit in that, it might be a tension headache. Or, so this ICHD3, you'll see this if you do research online, if you're looking up headaches or anything. It's the International Classification of Headache Disorders, volume or version 3. And let me tell you, if you ever go to a headache conference, they will spend at least a day and a half talking about this stuff. Because in headaches, it is all about the diagnostic criteria. And they can be very nitpicky about the language and stuff, not, for just the purpose of arguing amongst themselves, but for clarification, because there is so much overlap and there are so many ways to have a headache. So we try to be as precise as possible when it comes to diagnostics. So these are some of the characteristics that I would expect people to tell me about when they have these headaches. It's steady. It's not throbbing. It's not the whoosh, whoosh, whoosh like your pulse. Both sides of the head. This is going to get emphasized all the time because, once again, migraines tend to be one-sided. They can spread. It might start in one place and spread all over, but it tends to start one-sided. Mild to moderate, rarely severe. No nausea, no vomiting, photophobia, light sensitivity, phonophobia, sound sensitivity, osmophobia, smell sensitivity, so a lot of things can make you feel worse, make you feel more nauseated. There are some people who can just walk by the perfume counter at Macy's and get a migraine. That's a migraine thing. That's not a tension headache. So there are different categories, right? You can have acute, which is sudden onset, happen right then. You can have chronic, which is you have basically a headache all the time or nearly all the time, or you can have a recurrent. So it's more common than rare, but it's not common enough to be chronic. So, where you fall in the spectrum, think of it like a number line. And this is really the hallmark of it. Stress, muscle tension, neck, shoulders. And by shoulders, it's coming down the sides and it's kind of going into this area in here. Sides of the neck, back of the neck, and down into that meaty spot that you feel here. That's very classic for tension headaches. And then up, especially into the back of the head, like right here at the base of the skull. And sometimes because you have nerves, those notches that you have in the back of your neck, you have nerves that come out this way. There's one big trunk, branches go this way and come around this way. If that thing gets aggravated, that headache can spread from that area. But it doesn't start all over. It starts this way, but can spread. Okay, so when you see the neurologist, these are all the questions they're going to ask you. They may even give you a piece of paper or two to fill out all this stuff. They're going to ask you for all these details because, like I said, we try to be as precise as possible because we want to know what we're treating, and that determines how we treat it, even in terms of things like medications or other prevention strategies. So when, where, describe your pain, how long does it last, is it positional in any way? Does changing position affect your headache at all? Any history of head injury? Is there anything else going on in your life that could be a trigger? Is it more stressful than usual? And that can be all kinds of stuff. And stress is not always a negative either. I mean, you could have great things going on in your life, but you're just so busy that you don't have time to breathe or sleep. That can be a problem, though. Because, yes, sleeping right here. This is a nation of people who do not sleep well. That's a big trigger for all kinds of neurologic symptoms. If you have an underlying neurologic disorder, whatever it may be, Parkinson's, epilepsy, headache, stroke, if you do not sleep well or you do not get quality sleep, it will make all your symptoms worse. Doesn't mean they're permanent changes, but you will feel worse if you are not sleeping well. And then what do you take, if anything, that helps, or does it help? Are you taking over-the-counter medications? Are you taking an ibuprofen, a Tylenol, whatever the case may be, etc. So there is no test that specifically will tell you what type of headache you have. But if you have a tension headache, or you have a migraine headache, or you have cluster headaches, all these are primary neurologic disorders. So in other words, there isn't something else that's driving the headache. And what do I mean by that? So for example, strokes actually don't cause headaches, surprisingly. The vast majority of strokes. The kinds that do, the kind of stroke that does, is if you have bleeding, because blood and blood vessels is good. Blood on the surface of the brain is bad. It's painful. It's irritating. Those people have headaches. So when I'm talking about a primary versus a secondary, to me, that's a secondary headache, right? It is caused by that specific problem. You have bleeding in your brain, and your brain is irritated, or the coverings on the surface of the brain are irritated. If you have a migraine or you have a tension headache, the problem is neurologic from the get-go. You would have these whether or not you had neck or back problems. You would have these whether or not you had sleep. Those things can aggravate them, but the underlying cause is neurologic. Does that make sense? If you have a headache because your blood pressure is 200 over 110, the cause of your headache is treat the blood pressure, right? It's not because that's your migraine. So those are secondary headaches, and that matters because then you treat what the underlying problem is. If you have a primary neurologic headache, we got to treat that. Okay, so we'll look at things like blood counts, electrolytes, your thyroid, because all these things, if your electrolytes and things, so that's like your sodium, your potassium, what's your calcium doing, what's your kidney function, that's one of the things we'll look at too. If you're dehydrated, if you have infection, if you have some other process going on, that can be a trigger for all kinds of headache types. If you're prone to headaches, you're already a little bit hardwired for pain. So if anything else is out of whack, it can be a trigger for your headaches. So we will, and this is an easy thing to do, right? This is like, why would you not do that? Because sometimes you uncover things that you can manage. X-rays, CTs, that's not a typical thing for headache, but that's in people who are already diagnosed. If you come walking in, we've never seen you before, you've never had any kind of workup, then we may do some basic imaging, because everybody should get that. I don't know you from Adam or Eve, so I need to make sure there isn't something else going on in there that needs to be addressed. Tumors are not that common, but I sure would want to know about it. So yeah, we'll often do some basic imaging, and especially looking at the skull itself and your neck, because a lot of people, so here's the problem. We came out of the trees and we decided we were going to walk upright, but I'm pretty sure that dogs and cats and various other mammalian species don't really have like cervical stenosis and stuff the way we do, because from the time you're a toddler, you're walking around and you got this heavy head that you have to support on your spinal column the rest of your life. And so you get degenerative changes in the places that you have curvature, neck, low back. So we will look at that, because if you have like just degenerative disease, which is basically another word for arthritis type changes, or you have other conditions in that cervical spine. Maybe you have narrowing. Um, Maybe you have what they call spondylosis, where you have spurs, or you have listhesis, where they slide relative to each other, the vertebral bodies. Maybe you've got discompression, whatever. There are lots of ways you can have degenerative disease. But if that's the problem, then your headache may not really be a tension headache. Your headache may be more related to your neck issues. Doesn't mean you can't, again, have both, but so we look at that. We'll do MRs of the brain and the spine. And the reason we would do this, again, when you're talking about imaging, X-rays and CTs are fancy X-rays. That's also something useful to know. CT is a very fancy X-ray. It gives us really good information. But if you want to look at the brain itself, make sure there's nothing structural in there, or you want to look at the spinal cord, because you can have narrowing in the canal where the spinal cord goes through. Doesn't mean the spinal cord is getting pressed on, though. So you actually want to look at the cord and look for signs of chronic swelling or scar tissue that shows it's been compressed for a long time. All those kind of things are going to show up on an MRI. So that's really the difference between whether you get a CT or an MRI. What's the question I'm asking? What's the anatomy I want to look at? Okay, so diagnostics, yeah. If you've already had a workup, if you already have a diagnosis, this isn't really going to be useful to go and repeat this stuff all the time unless there's been a significant change, like a change in the frequency of your headaches or the character of them, the way you experience them. Because then you have to ask yourself, am I dealing with a different problem, with a new problem? So that would be the only reason to go and repeat a bunch of that stuff, is that something changed. All right. So looking at acute management. So acute is, this is going on right now. You woke up this morning, you got this headache, it's making you miserable. Rarely do we see these folks in my setting unless it's something else going on as well. They may have come in for something different and we're asked to see them because they have this, tension headache that's a little bit out of control because they're in the hospital in our lovely fluffy beds, who knows. Or again, maybe they're a migrainer that's superimposed on a tension headache. But the goal of treatment, and sometimes people will come to clinic with these things, because when possible, we try to spare people the hospital, because as we all know, if you go into the ER with a problem, if you're not having a heart attack or a stroke, you could be sitting in the ER a long time before any of this stuff gets addressed. But if I'm seeing somebody for new pain, I'm going to be looking at what can I do to improve it or make it go away as quickly as possible, because that's what you're there for, right? There are no real guidelines for this. Like a lot of medicine nowadays, we're supposed to be evidence-based, and there are very definitely guidelines for all kinds of stuff. There are actually guidelines for managing migraines. There are guidelines for managing stroke. There are guidelines for managing heart attacks, not for tension headaches. And a lot of the stuff that we do, I wouldn't say it's strongly evidence-based. A lot of it's kind of extrapolated from migraine, which is interesting because as far as we know, the pathology is different, but we don't have a great handle on migraine pathology either. There are like 5 different theories on that. I think it's going to end up being one of those things that over time, as our science gets better and we start asking the right questions, we're going to find out a lot of things that were under the same umbrella are really different, right? And again, we don't even have, if you don't have a guideline, you don't really have any criteria of saying, well, this works better than that, because that means nobody's really done the studies. There's no data. So this is the big one for anybody who suffers from any kind of headache. If you feel it coming on, treat it then, because you'll have a much greater chance of success than waiting till it's well established and you're miserable. You try to head it off at the pass. You get it when it starts. This also is kind of, go big or go home. We feel like if you're going to treat this acute headache, treat early and just throw the kitchen sink at it. This is not the case of we start slow and, start low and go slow like you do for blood pressure medicines and things like that. Nope, this is what medication am I going to use? And I'm going to give, if not the maximum dose, something pretty darn close to it. I'm not going to go with the minimum. And then this actually, and this is a recurring thing for headaches, for all kinds of headaches. The problem, you got to think of it like asthma. if we're having to do rescue management, meaning we got to treat these headaches and it's 14 days or more a month, you're going to end up with some kind of something called a rebound headache, which is if you don't get those medications, because your brain will get used to it. And then if you don't get it, you get the headache. And that's kind of across the board, all of these. And when I talk about rescue medications, this is for these episodic events. It's like if you have asthma, you have an albuterol inhaler and you should not leave home without it. Because if you have an asthma exacerbation or you start to tighten up, you start wheezing, you give yourself the albuterol and that should stop it. If you have to use that more than 2 times a week, then you need to be on maintenance medication. We kind of look at headaches that way too. If you have frequency like 14, 15 headache days or more a month, we may need to talk about some kind of preventative strategy. But once again, with tension headache, I have a great deal of freedom with that because there aren't really any guidelines for it. So when you're talking about acute headache, you woke up with it that day or it developed during the day, that's really what acute means. It's sudden, starting right then. NSAIDs. So NSAIDs, non-steroidal anti-inflammatory drugs. So that's going to include all your ibuprofen, naproxen, diclofenac, which is Voltaren, ketoprofen. This one, well, I'll go over each of them. But anyway, that includes over-the-counter things. And the reason they're called NSAIDs is they are anti-inflammatories, but they're not steroid. That's where the name comes from. And aspirin, even though it says or aspirin, technically aspirin's an NSAID as well. So, it's been a long time since we routinely told people take aspirin for pain, but it is actually very effective. It works. But I wouldn't do it frequently, especially as we get older, linings of the stomach and things like that tend to thin out and we're more prone to issues like bleeding problems, right? And certainly aspirin and most of the NSAIDs can be associated with like GI bleeding, especially in the stomach, but even lower down in the gut if you're taking them regularly and at kind of higher doses. So ibuprofen, the over-the-counter ibuprofen is 200 milligrams. That's the way it comes. The way we dose it is 400 to 600, so you take 2 or 3 of them. Then naproxen, which is naproxen, same thing, 220 to 550. When you start getting up in this range, that technically is prescription strength. Like an ibuprofen prescription strength is 800. The reason I don't even put that up there is that in the neurology world, there is absolutely no data that says you get more bang for your buck going from 600 to 800, but you certainly increase your risk of side effects and things. So I never prescribe 800s. Naproxen, same thing. You can take 550, but if you can get the job done at a lower dose, that's probably safer to do. Now, you're probably going, wait, didn't you tell me I go to do the big drug, when I get my headache, I take the higher dose? That's a one-time thing. If you're having to take medication fairly often, don't go to the higher range for these things. But if you are somebody who gets 1 or 2 headaches a month or something, then by all means, when you take it, take more like the, upper end of it. Aspirin, 500 to 650 milligrams. So the way aspirin, it depends on where you are in the world, what the dosing is. In this country, we have 81 milligram baby aspirin, and we have 325 milligram. So, whereas in other parts of the world, you can get 75 milligrams, et cetera. That's what it is in the US, 81 milligrams, 325. So what this is basically saying is you can take up to 2 full aspirin, and you're going to have a hard time doing this in the US, but if you want to cut up little aspirin pills, you could probably figure it out. But I would say if you're going to take aspirin, take 1 or 2 at a time of the full dose. Baby aspirin is fine if you have had a heart attack or a stroke or something, but it's probably not going to be very useful for pain management. Diclofenac, some of y'all might be familiar with this as Voltaren, which is, it comes as a gel too, like if you have arthritis, you can put it on topical, but it does come as an oral form, and that's the dosage medication. Cambia is a new formulation they came out with probably, gosh, how long has it been now? I guess it's been out at least 10 years now, but it's great because it's powdered. So you can put it like a tablespoon of water, it dissolves great, you drink it, absorbs very quickly, works like a charm. But those are prescription. These guys here, they work very well, but they are prescription. So you would sort of have to have had a diagnosis and have fairly frequent headaches such that your primary or neurologist thinks you're okay to be on these. And this is also assuming you don't have heart disease and you don't have kidney disease, because these things can be tough on kidneys. So if you have any kind of kidney issues, you really ought to avoid this class of drugs altogether. And then cardiovascular, because of their prostaglandin inhibitors, and so it can have an interaction with the actual vessels, the actual blood vessels. So they really try to minimize use of these in people who have known coronary artery disease. The bleeding issue that we talked about. So for the average person with no kidney issues, no heart attacks, or anything like that, and no history of bleeding ulcers in the past or anything, and you're taking an occasional dose, that's not going to be your problem. You really got to worry about it if you're taking significant doses over time, frequently over time. These, interestingly enough, I think this is kind of an interesting commentary. So Tylenol is the other over-the-counter medication that we're all familiar with. It is not an NSAID. Its mechanism of action is totally different than these drugs. Works in a different way. But the NSAIDs and the aspirin, you tend to have fewer issues with medication overuse headaches. And again, those are the headaches that if you're taking something frequently and you stop taking it, you will get a headache. Kind of like a caffeine withdrawal headache. It's the same principle. Your brain likes that stuff. It's used to it. If you take it away suddenly, it will tell you about it. And then, but Tylenol, butalbital is an old barbiturate. If anybody here has ever taken Fioricet, that's butalbital. And then codeine, also old school, that's like Tylenol 3s kind of thing. And there are formulations of Fioricet that have all three of those, the caffeine, the butalbital, or pardon me, the codeine, the butalbital, and the Tylenol. Yes, sir.
Aleve.
Aleve, Aleve isn't that naproxen? I think Aleve is naproxen, yeah. So, and that's what we write. You can take that over the counter. I try not to use too many of the commercial names, number one. I was always trained that you have to know the chemical name, and number two, if you're buying generics, it's good to know both. But Aleve is, it's this one right here. Oh yeah, you're right. I should have put Aleve in there. I didn't even think of it. And that's why you sort of get away from the manufacturer things, because it's basically like saying Kleenex for facial tissue, Anyway, so moving right along. So looking at how do these all rank? Same, okay, we have some trials. The NSAIDs tend to work better. And I think most people have had that personal experience too. Plenty of people over the years have told me that, yeah, I take Tylenol, because I have kidney disease or whatever, but it doesn't work great. I think it actually is quite effective. And the way is if you have to take it chronically for something like your arthritis, because you can't take the anti-inflammatories or anything, you can do the trial of, I'm just going to stop taking it and see what happens. And I guarantee you'll notice a difference. Does not mean it's curative, though. And it depends on why you're taking it, right? If you have bad arthritis and everything, nothing is going to take that away. What we try to do is make it manageable, except possibly joint replacement, but it depends, right, on what the problem is. Okay, this is the standard dosing for Tylenol if you're doing extra strength. Extra strength, 1 is 500, 2 is 1,000. The bottle will tell you can take up to 4 grams a day. That's 4,000 milligrams. Generally, we tell people you really shouldn't take more than 3,000 a day. That's probably the safest thing. So NSAIDs, aspirin affect kidneys. NSAIDs, kidneys. Tylenol, liver. It gets metabolized through the liver. So there are certain people who shouldn't take it, but that's not a big population. Tylenol is also the one that if I've got pregnant ladies, especially if they're second trimester or later, I am never giving them NSAIDs. They get Tylenol, or Tylenol, pretty much. If you do this combination, the aspirin with the caffeine with the Tylenol, this is Excedrin extra strength, etc. This is really a migraine medication. There's no indication whatsoever for tension headache, but these are the over-the-counter things that are available. It's not going to hurt anything, might help, but that's really a migraine treatment right there. Ketorolac, as far as I'm concerned, is the wonder drug. I love this stuff. It's basically super ibuprofen. We can give it as an injection in the muscle. We can give it IV. Technically you can get it as a pill and you can get it out in the community, only prescription. But when this drug first came out, literally we thought it was just the greatest thing. It's very effective, especially in surgical patients. But we found out that if they were taking it more than about 5 days and they went home and took it, they all developed, like 25% of them developed bleeds. So we're careful about it. But it does work very well, especially in the acute setting, where you're only going to give 1 or 2 doses or something. It works very, very well. If you have, and this I think is kind of an important thing to know, if you have nausea or vomiting with your headaches, that's not going to be a tension headache. The nature of those headaches, where they occur, the systems involved, that should have nothing to do with nausea and vomiting. So if there's nausea and vomiting, that's coming from something else. And, could be that you also have migraines. So when does it become chronic? When you exceed this. If you are talking, 15 or more days a month, and this has been going on for more than 3 months, you have now graduated into the chronic category. You have chronic tension headache. This is true for all headache disorders, frankly. When you develop a chronic condition, you do tend to be less responsive to medication. Some of that may just be you've become acclimated, so to speak, so it's less effective. Stress, anxiety, depression. Like I said, you have stressors in your life. None of us goes around wrapped up in, cotton wool. So you can't always avoid this, but there are definitely times in your life when it's worse than others. And that can be a trigger that makes your headache, your underlying headache disorder, more severe, more frequent. And there's no great answer for that, right? Because again, none of us just, lives in a little cave. But we'll talk a little more about non-pharmacologic things. So prevention is not as straightforward with this as with migraine, because once again, we're not entirely sure what the mechanism is here. So it's hard to say, well, I want you to do this to prevent that when you're not sure what the underlying problem is. High risk for developing medication overuse headaches when you have a chronic condition. MOH just means medication overuse headache because I got tired of typing it. When you have secondary headaches that we talked a little bit about before, so your headache is not a primary neurologic disorder, it's caused by something else. So tumors, stroke, and by that I mean bleeding strokes, not ischemic strokes, intracranial hypertension, so the intracranial pressure is elevated, and that can happen for a few reasons. And including things like idiopathic intracranial hypertension that we used to call pseudotumor. So these often are women who have vision changes is usually our big clue, and this just this chronic headache that never gets better no matter what. And we look in their eyes and we can see that they have swelling in the back, in the disc, so behind the eye, and they have changes in the optic nerve, so they can have vision changes. And the danger is this is elevated pressure. It could cause you to go blind if it's untreated. That's a secondary headache. You've got to treat the hypertension. Glaucoma, that is elevated pressure in the eye itself, which is also something that can make you go blind. Giant cell arteritis, not all of us are over 55. It's something you really don't see in anybody younger than that, but it's an autoimmune condition that causes a vasculitis. So it's temporal arteritis, giant cell arteritis, autoimmune. How do we treat it? Prednisone, and lots of prednisone. You can take anywhere from 60 to 100 milligrams a day, and you might be on it for 1 to 2 years. But it is one of those things that we consider very high risk for stroke and for blindness. So you have that kind of headache, that's not a tension headache. So you have any of these conditions, even if you have head or neck pain, it's not a tension headache. We have to address these issues. Okay, and then of course, if you have any kind of neurologic finding on exam, if I'm, going through all my steps and I find something that is an abnormal neurologic finding in it, and it can be subtle, it doesn't have to be like, one side doesn't work. But if I see something like that, then I'm going to be looking for other things as well. Doesn't mean you don't have a tension headache, but it's my job to make sure that there isn't something else potentially dangerous going on or that we also need to address. Okay, so prevention. This is actually a big one. Like I said, we're a society of people who don't sleep well for one reason or another. So if you can get regular sleep and wake cycles, just regular routines of bedtime, wake time, regular exercise, at least 30 minutes a day. It doesn't have to be any specific type of exercise, doesn't even have to be aerobic. You just got to get out and move, basically. Regular meal times. Skipping meals, not a good idea. Although, there's a little wiggle room. I mean, a lot of people now do these, like, sort of, I forget what it's called, but it's some type of a fasting kind of thing. They'll go 12 hours or 16 hours without eating. If you don't get headaches and you don't get low blood sugar and you don't feel like, you don't feel bad, I don't know that that's bad for you. But if you do have some of these underlying things, you really should make sure that you are eating regularly. And that doesn't mean you have to eat frequently. It just means you want to eat. And boy, if you have something like diabetes, that is actually really important, because if you do skip meals, people are like, oh, I only eat twice a day or anything. The problem is if you have diabetes, you already have abnormal metabolism, right? Things aren't working quite right with the way you uptake and process sugar. So if you go long periods of time with no food at all, the body can register that, and then it will tell the liver to dump sugar into your bloodstream, thereby, causing even more problems with glucose control. So for many of our people, this is actually an important thing. Okay, and then the triggers: lack of sleep, certain foods. This is why we ask people to do headache diaries, because not all people have, no two people have even the same headache in the same way. Everybody has their headaches in their own way. You may not have any food triggers, but if you keep a headache diary, which is, it doesn't have to be volumes. It's literally, on this day, had a headache, started it, whatever. I mean, just try to look for patterns. It's all about pattern recognition. So if certain foods seem to be a trigger for you, then by all means write them down. Now, I will say, once again, like I said, no clear guidelines for these type of headaches. This stuff, especially these things, that's really migraine management, to tell you the truth. When you're talking about smells or foods or things that are triggered, that's frankly more relevant to migraines than to tension headache. But if you read up on headache stuff, no matter what kind of headache it is, they're always going to tell you about this, because to our mind, it's all fairly common sense anyway. If you do have a headache of any kind, and I always laugh at this because I'm like, how realistic is this? A lot of people get headaches at work. How many of us can leave work and go in a quiet, dark place? Doesn't happen very often, but it sounds nice. If you're at home on the weekend, then you do this. Okay, stress management. And that's a big one, because like I said, if you have any underlying neurologic disorder, if your stress is starting to overwhelm you, it's going to make it worse. So that includes things like biofeedback, cognitive behavioral therapy, relaxation techniques like your yoga breathing. I mean, they can be very low tech. They do not have to be complicated, and you don't necessarily need a specialist either. This is really effective for a whole lot of things. This is Tucson. It's kind of hard to get therapists who are even certified in this, in CBT, but it is a very effective technique for many things. Medications, yeah, I mean, I'm allopathically trained. I think medications are useful, but just be aware that they have their limitations, and you can only take it so far. So I don't think we should be always dependent on this taking care of the problem. And chances are, even if you're taking medications, they will help, but they won't necessarily solve the problem. And sometimes our goal is really just to make it more manageable. And then prevention, in the case of tension headaches. And I think also, oops. Oh, I guess I was there. I thought I had another one. There we go. Well, no, back at the beginning. I seem to be missing something. Well, anyway, so, I am, and like I said, I'm a firm believer in helping manage symptoms with medications, but I think everybody should be really clear, especially when it comes to neurologic disorders, that there really are no magic pills, magic bullets, etc. Very rarely are we going to have one medication that just solves the problem. So it's a combination of things. Lifestyle changes are very important. And from our point of view, that means that you are buying into it and you are making a commitment to manage this issue on your own as well. This is certainly true for migraines. I think the other issue in America, too, is that we have kind of come, all of us on both sides, that kind of come to expect that, if I have a symptom, you have a pill, or you come to me with a certain problem or something, and I do my workup, etc., there is going to be a medication that takes care of it. No. When it comes to most neurologic disorders, there is rarely a cure, so we are looking at symptom management. But managing your symptoms has a lot to, is much broader than just taking a medication. And that's even true for like migraineurs and stuff. But we don't have nearly for these type of headaches, which, like I said, this is the most common headache disorder out there. But it's not like we have a lot of choices. I mean, how many medications do we talk about? Less than a handful, right? Or, well, if you compare that to diabetes medications, blood pressure medications, epilepsy medications, I mean, literally, I have choices and choices and choices. You have the non-steroidals, you have aspirin, you have Tylenol. And you can have combinations of those things, but that's about it. Muscle relaxers. A lot of people out there on things like, methocarbamol, which is Robaxin, or they're taking Flexeril, just like Benzaprine. I mean, a lot of muscle relaxers. In the old days, they had, the benzos like Valium, diazepam. I'm trying to remember that one that we used to use that I think has been off formulary for a few, Soma. Soma was a big one back a few years ago. And a lot of these things are habit forming. They make people drowsy, they're sedating, and they don't work. People may have some blunting of their symptoms, but usually it's more the sedation part, which is not good. You shouldn't be out there driving on those things or anything. But there's nothing that we have found, looking at like hundreds, if not thousands of people over time that shows that they really get good results from it, more than more conservative management. I don't think that we have really looked at other options like chiropractic. I don't even think that's a word, I made it up. Chiropractic manipulation or acupuncture, etc. I think some of these, what we call alternative therapies, can be quite helpful for people. I mean, what have you got to lose, right? Problem is, of course, it won't be covered by your insurance, so that can be a little bit limiting right there. My only caveat in chiropractic manipulation is don't ever let anybody do high velocity, quick maneuvers with your neck. But other than that, that could be helpful. Massage, deep tissue massage, same thing. Don't let people do fast, abrupt movements or things that really, a lot of torsion or stretching, because especially these arteries back here are a little bit vulnerable, and I have seen people come in with strokes from dissection, so always be mindful of that. Neck manipulation, dissection is when you get the arteries that go up into the brain, so these would be the vertebrals back here, these are the carotids here. They're 3 layers thick, and those layers can separate, and that can cause both bleeding and clotting. So it's a known.
So they would have to do something like this.
Exactly, like again, rotational stuff that's very fast and abrupt, or it's just, I think, extreme stretching and thing. I knew a guy who was leaning backwards like this, cleaning out the clothes washer, for his wife, lovely, nice man. He dissected one of his arteries there. Not that that's really what our talk is about. So sometimes things just are kind of random, but part of it is just what I do for a living. I'm like, nobody should be messing around with your neck in any way that's abrupt, that's fast, or causes too much movement, especially not fast movements. Okay.
So thank you, Fran. Thank you. Fran.
Mm-hmm.
So I've got a couple of questions that have come in that I wanted to ask you before we turn it over to your in-person audience. Somebody actually asked if you were taking new patients, and I know the answer is, but they might have missed in the beginning that you are just inpatient.
Yes,
Here.
that's correct. I'm just inpatient. Mhm.
Right. So if somebody was looking for some help with headaches, you do work for Center for Neurosciences, and that could be an option for somebody.
Yeah, and it sort of depends. I think neurologists are so hard to get into. I mean, there just aren't enough of them. I would always say just get in the door, because all neurologists are trained to treat headache. And if they feel like they need to escalate, they can refer you either within the practice or they can refer you up to, Mayo or Barrow or something. Probably Mayo more than Barrow for that. But yeah,
Okay.
just get your foot in the door. That's the hard part.
Thank you. Now, if somebody has vision issues, and maybe they've got blurry vision, or they continue to have that, are they more likely to get a tension headache?
Not really. Like even eye strain headaches, I think they kind of debunked that. But vision issues should never be associated with tension headache. That's neck and shoulders for the most part, base of the skull. If you have vision issues, blurred vision, difficulty focusing, whatever, the first thing I do is go and get a dilated eye exam. So go to an ophthalmologist. And, they can look for things like disc edema, changes with the optic nerve, looking at your retina. They check the pressure, so looking for things like glaucoma, diabetic retinopathy. I mean, there are lots of ways eyeballs can go wrong. They're not very big, but they're very complicated, and they're very closely tied to the brain. And so I've certainly seen on the inpatient side where we get people sent to us from the eye doctor because of vision finding. Either they're worried about ischemic strokes and atherosclerosis because they see changes on the exam, or they're worried about somebody who has increased intracranial pressure. Yeah, so I'd always start with a good dilated eye exam.
Okay.
And then now, if you have sudden vision loss, if you have a field cut, like in both eyes, or you have double vision, go to the ER. That's not an ophthalmology thing. That's go to the ER. I'm going to rule out stroke until you prove otherwise to me.
Okay, great. Now, what about TMJ? Can that cause more severe tension headaches? And
yeah,
so tension headaches lead to worse TMJ.
Well, that's the thing that's a little bit tricky because, I make it sound like, well, this is tension headache and these are your symptoms and this is the way it is. But there is a lot of crossover and you can have that and still have these other things. And if you develop these other things, they're going to make your tension headaches worse. And sometimes for us, the way we would distinguish it is, once again, I looked at everything. If I find a cause for your pain, like you have TMJ, which is essentially arthritis in your jaw right here in the mandible where you have this joint. If you have that, then I'm going to say, oh, your headaches are probably really driven by this, so we need to treat that. That to me is not a primary neurologic headache. And if you have, again, cervical disease, you have arthritis in your neck or something, you're going to have pain in your neck. It's going to go down into your shoulders. It's going to go up into your head because all these things, that's the way the nerves travel. But that's not necessarily, it'll aggravate tension headaches if you have them, but they don't cause tension headaches. Does that make sense? And it's a little bit of splitting hairs, but if there's an underlying cause that fits the headache pattern, then to my mind, that's more the problem than an actual tension headache.
Okay. Yeah, and I know it's hard to identify sort of what is the actual, what's leading to what. Right?
Definitely have more than one thing going on at a time.
Yeah. I know you just talked a little bit about maybe some acupressure. Have you tried using like the pressure points? I know that there's certain pressure points that are supposed to work specifically for a headache.
Well, that's a good question. Yeah, and that also brings up another issue for people that do have what they think is a tension type headache, and maybe they do have some cervical spine disease. I mean, I used to have a guy who was a cervical fracture, an old surfing accident, and I would do trigger point injections on him, which is basically just putting local anesthetic into the belly of the muscle so that it helps relax the spasm in the muscle, and so that would give him relief. You can do those kind of things. Now, that is superficial, though. That's not the same as the epidural injections or the facet joint injections, which is like the articulations in the vertebra themselves. Those are specialists. Those are like anesthesiologists and pain docs that do that. I would never do that. in terms of this kind of thing, pressure points, I have heard good things about that, but I have no training in it whatsoever. Probably wouldn't be a bad idea. But and feet, I think the whole reflexology thing, I think, is probably worth trying too, because I think there's enough data that shows that people are helped by those things.
Right. Okay.
But again, I have zero training in any of those things.
No, I just didn't know whether you had had any experience or had seen people who have had some success maybe with their headaches using, reflexology, for instance.
I'm going to start asking them. I would say in general, the population I see, no, because that's why they're in the hospital, right? They don't have good handle on the management of their chronic issues. Folks that you don't see in the hospital, that you see out in the community, that you see in the clinic, yeah, if they're doing it, it's obviously working for them because I don't see them.
Right.
That is a little bit of a caveat, as I always see the worst case scenarios.
Thank you. Okay. I think that wraps up all of my questions. I am going to wrap up with our online audience. I want to thank you so much for being here. I'm going to turn it over to you to answer any questions that are in person today. So thank you so much for being here, Fran.
Wonderful. Happy to be here. We'll talk about migraines another time if we want to do that.
Thank you. Thanks so much for being with us today. Our next talk is going to be on Tuesday, March 19th. It is Movement Matters, the Impact of Neurological PT. Again, Tuesday, March 19th at 10 a.m. So if you're interested in this talk, please give us a call at 520-324-1960. Again, we have quite a few classes coming up next week. So that's the first one. After that, on Wednesday, March 20th, we have Behind the Scenes, the Bottom Line on Colorectal Screenings. That is on Wednesday, March 20th at 3 p.m. And then benefits of Be Fast, reducing the damage of stroke. Such an important topic. I'm hoping that you'll join us for that too. There are still seats available in person for the last two talks, I know for sure. The phone number again is 520-324-1960 if you are interested in either getting the link for the online or you would like to register for in person. We hope you have a great day and we'll see you soon.